This week on the BackTable podcast.
If you do a lot of pelvic dissection, opening the pelvic spaces, specifically complete periodectomy of the ovarian fossa, or the patient has deep endo and you're treating that, and you open all the retroperitoneal spaces and you leave the ovaries, there is a likelihood of the ovaries getting really retroperitonealized. So it become underneath the peritoneum. And then this actually by itself causes pain. And if for any reason repeat surgery is indicated, the surgery becomes significantly harder.
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got another good friend and guest coming on the show today, Dr. Emad Mikhail. Emad, how are you?
Hi, Mark. How are you doing?
I'm good. Thanks for coming on. We appreciate you. And it was good to see you in person recently down in New Orleans. That was fun.
The pleasure is mine. Thank you for having me today.
Our show is, if it's good, it's because we are lucky to have such great guests who take their time to come on. And you're no slouch. Dr. Mikhail is a associate professor of OBGYN at the University of South Florida, chief of his division of gynecologic subspecialties, and director of inpatient gynecology at Tampa General Hospital. And he's going to talk to us today about endometriosis after hysterectomy, which is something that is certainly a challenge for many of us. So as we do in every episode, we like for our listeners to get to know our guests. So do us a favor and just tell us a little bit about yourself, your practice, and really how you got to be where you are. Because I think one of the things that really made me want to do this was just hearing everybody's path to greatness. And we have, it always seems so daunting. And then you hear folks that have done amazing things and realize they shared some interesting ways they got there that aren't necessarily the way we thought. So yeah, tell us about yourself, your practice, and how you got to be where you are now.
Well, so I came to the U.S. in 2008. I finished medical school and I finished general surgery training in Egypt. And then I came to the U.S. I moved to Toledo, Ohio for OBGYN residency at the University of Toledo. It was quite a change in weather and a lot of things from, Cairo to Toledo. Finished my residency and I wasn't sure what I'm going to do in my life. I was not sure until one day I went to AGL and I kind of found, this is maybe for me. So I applied for, mixed fellowship. I didn't get it the first round, so I didn't match. Then worked as a generalist for a couple of years and kind of applied and matched in fellowship. I did fellowship in University of South Florida, and then I stayed on, and now I'm the division director at the University of South Florida.
That's a great story. And it's so many people that I've talked to along the way that are, again, doing great things like you are, have had a less than linear path to their success. So what was the reason you came from Cairo to Toledo?
I had a young family, and it was kind of very hard for us to see a path of where we want to be if we stayed in the same place. So
are you from Cairo?
Yeah, I'm from Cairo, born and raised. So I kind of say, maybe it is time to move and find an opportunity somewhere else. So I applied in the match and I got Toledo.
I'm in Kentucky and I've been to Ann Arbor a couple different times in my life. So I've driven through Toledo a handful of times, or at least driven around it to get up, certainly through it to get to Detroit when I go up there. But, it used to be, I think that used to be part of Michigan. There was some war like way back when where Ohio won Toledo, the Toledo War, or something like that. I don't know, but that's not why people are here to listen to it. So Toledo, and then fellowship in South Florida, and then have stayed on there the whole time. And so, you and I have spoken over the years about practice building and those kinds of things. And because were you the only MIGS person for a little while? Were you always part of the group? I can't remember.
Definitely. So I finished in 2016. And I was the only mixed, doc there for 7 years. So I only hired my partner last year.
It's a big transition going from 1 to 2, having done that now a couple of times. So congratulations for that. But building things is tough, but it can be incredibly rewarding.
It is very rewarding, and we're so lucky. Since then, I hired a mixed partner, and then I hired a pediatric addressing gynecologists, and now we're thinking of expanding more. So it is very exciting time for us.
Wonderful. And having success in building programs comes from building a practice and from excellence in clinical care and surgery. And clearly that's how you've done it. I think when we think about some of the most challenging cases in our MIGS world in GYN surgery, I think of the repeat surgery, right? Once you've gone into a space, operated and come back, it's a big part of how we counsel patients. It's a big part of how we address potential complications is, if we're going to operate, remember, if it doesn't provide the results that you want and we have to go back, that next surgery certainly can be very challenging. And so before we kind of get into the second surgery, talk to us about the role of hysterectomy in endometriosis. I think it's something that certainly a lot of our patients think about as being curative in that sense. And talk to us about what we understand about hysterectomy as a treatment for endometriosis.
Thank you, Mark, for this question. This is a very important topic, is that when to do a hysterectomy in patients with endometriosis, from the patient perspective as well as from the surgeon perspective. So, some patients come and say, if I do a hysterectomy, I'm going to, get cured from endometriosis, get cured from pelvic pain, and I'm good to go for life. And this is very rarely the case. Actually, hysterectomy, when you think about endometriosis, it is basically an extrauterine disease because endometriosis of the uterus is actually called adenomyosis. So, doing a hysterectomy does not necessarily treat endometriosis. But it is a great kind of step to do if you are treating adenomyosis or if you're treating very significant cyclic pelvic pain and dysmenorrhea. But for endometriosis, hysterectomy usually does not cut it. So you have to kind of many things. Number one, make sure that you excise endometriosis that's present outside the uterus, and then do a hysterectomy as a complementary treatment in cases that the hysterectomy is indicated. But also make sure that the patient does not have a concomitant, other pain generators that would kind of result of residual symptoms or recurrent symptoms.
So what are example of other causes?
You are the expert in this, interstitial cystitis, gastroenterology, myofascial pelvic pain. Those are kind of very commonly occurring consistent symptoms that hysterectomy will not address.
Right. And I like that word you chose. It's not something that can be there. It's something that's actually often and more likely to be there along with endometriosis. Those conditions, IC, IBS, musculoskeletal pain, are often commonly co-diagnosed. So yeah, it's not just that these are other things on your differential. These are things that are more likely to be found even when you do find endometriosis.
Agreed. It's extremely common to have those conditions in patients with endometriosis. And on the other side, from the surgeon perspective, it is, kind of very hard to go to your surgeon and then the surgeon will tell you, oh, I'm going to remove your uterus and this will cure all your problems. And this is actually, when you think about it, this was the education and the surgery training in gynecology like 50 years ago. You do a hysterectomy, or actually do a hysterectomy and oophorectomy and leave all the disease behind, and the patient will be okay, which is not the case.
So let's talk about why that's not the case, because I think when we talk about hysterectomy, we're talking about uterus and cervix traditionally, but we have to counsel about whether or not to leave the ovaries. Many women who are suffering from endometriosis are reproductive age, right? So younger, premenopausal, oftentimes remote from menopause. And so the decision to take out ovaries is not a small decision. Clearly, if they're getting a hysterectomy, they've made the decision that they're not interested in future childbearing, but potential impact on bone, heart, other systems that are not small deals, and how we counsel on that. I think historically the thinking was make them menopausal, the problem solved, right? They don't have hormones, but that's number one. It's a big decision and we have to think about, is it worth it? But number two, is that going to solve the problem? So talk to us about hysterectomy with BSO, without BSO, as it relates to endometriosis, and what you understand about the likelihood that patients still have symptoms post-op.
So One important point that I have to emphasize is that in deep endometriosis, nodules secrete their own estrogen as a mechanism of self-survival. So removing the ovaries of the patient and push them into surgical menopause, specifically when the ovaries are normal, not diseased, I believe that this is not the right decision, because removing the ovary as a source of estrogen does not cure the endometriosis. Actually, the endometriosis will still be there, will still proliferate, and will still cause symptoms. ACOG in the last practice bulletin reports about if the patient is elderly, 60 or older or 65 or older, they can offer them an ovarectomy with potentially no harm. But if you have a premenopausal patient, taking out the ovaries has a huge implication on the patient health. If the ovaries are normal, ovarectomy is not indicated. Excision of endometriosis is the way to go. One caveat that I have to emphasize is that if you do a lot of pelvic dissection, opening the pelvic spaces, specifically complete peritoneectomy of the ovarian fossa, or the patient has deep endo and you're treating that, and you open all the retroperitoneal spaces, and you leave the ovaries, there is a likelihood of the ovaries getting really retroperitonealized. So it become underneath the peritoneum. And then this actually by itself causes pain. And if for any reason a repeat surgery is indicated, the surgery becomes significantly harder. So ways to prevent that scarring has to be thought about: ovarian suspension, something like that, until the space kind of heals off and the ovary does not become retroperitonealized.
So talk to us about how you do that.
So if you end up doing a peritoneectomy or opening the parectal space specifically, and the ovary is normal and you are keeping it, I usually suspend the ovary to the ipsilateral round ligament. It keeps it above the space until the space is retroperitonealized. I know other surgeons who suspend the ovary to the abdominal wall with a temporary stitch that can be removed in 2 days after. So people are, different ways people are doing to prevent that falling of the ovary into the dissected space, and then it becomes retroperitonealized.
If you're sewing it to the round ligament, are you using just like a Vicryl, or are you using something permanent?
Yeah, no, I don't use something permanent. I use, absorbable stitch that, I get absorbed in a week or two. By that time, the peritoneum regrows and the ovaries will not be retroperitonealized.
Now, I think this is one of those areas where we just don't have a lot of data, or is there data on that? From last time I looked, I don't know of any.
No, actually, there is very scarce data about this, and the main reason is that we cannot do just repeat laparoscopy just to find out if what we did last time worked or not. This is kind of unethical. So any surgical randomized trial will not ever be done, because we cannot do a second look laparoscopy anymore.
Right. I mean, it used to be, it was easier to do that back in the day, I think, but these days we have to be very thoughtful about the surgeries. We talked on the show a bit about the peritonectomies and sort of how aggressive to be. And there's a wide range of opinions on that. I probably sit somewhere in the middle. I think there's some value to peritonectomy when you're taking away disease. I think some folks will take away even a normal peritoneum, and sometimes you find little lesions, but I guess, at this point, I think we're in more of the expert opinion phase of this, but I'm always curious to know what people think about the value of doing sort of wide peritoneal resections when they have visualized or known endometriosis that appears relatively superficial.
This is a great question. And the answer to this, if you ask 10 people, you will get probably 10 different answers. So my thoughts, if there is a lot of disease widely dispersed into the peritoneal, like let's say ovarian fossa peritoneum, there is a lot of disease. There is probably skipped lesions elsewhere. So doing a complete, we call it a butterfly wing peritonectomy. So doing a complete peritonectomy in these cases might be very valuable. But if the lesions, you have two lesions very far apart and the peritoneum, the intervening peritoneum is completely normal, you might be doing too much and you will risk having severe scarring afterwards that I'm not sure if actually you were providing a lot of benefit. And so I think there is a phase of judgment that the surgeon has to employ to see what better serves the goal. One thing I learned throughout the way is the surgical saying that less is more. Not necessarily that you can do the surgical step, you have to do the surgical step.
Yeah, I mean, again, so much of it has to do with the true pathophysiology of the disease, right? If we think it's something that is, at the cellular level, if there's going to be stuff we can't see, right? If we're doing quote unquote complete peritonectomies, we know it spreads, peritoneum grows back. Is it going to spread if we're not getting it all? And it's hard for me to visualize in my mind how we're quote unquote getting it all, right? Because there's going to be peritoneum left on the round ligaments or, the pelvic side walls that are, more anterior, the abdominal. We're not taking it all. So there's some disease, and there's going to be some disease likely on the sigmoid or little microscopic disease. And so whether you think it spreads from there, we're always leaving something behind. And so, I think that's where understanding how the disease comes about, where it comes from, can really help us understand what we need to be doing. And clearly some people are benefiting from wider resections. And so I think there's, it's important to have surgeons who know what they're doing, who understand and feel comfortable in these spaces. But it's always something that it's always tough to tell patients, I just don't know. And that's the reality of it for most of us. But
actually, in my experience, a lot of patients really, really appreciate when you say, I am not sure. I'm going to undo by mist, but I am not sure. And actually, they see this as a sign of confidence, as a sign of experience, not as a sign of being naive. So I use this a lot. When I'm not sure, I say I'm not sure. And the concept of complete cytoreductive surgery that people kind of adopt from ovarian cancer into endometriosis, again, it is very debatable. Again, this is a benign disease, and complete periodonectomy has its own complications. So again, judgment is important.
No, I think that's a good conversation. I think it's important to tell patients to be transparent. Look, this is what I believe to be going on. This is what I understand about it. And also to say, I don't know it all. And if you want to get another opinion, you're welcome to do that. I mean, I do that every day in clinic. Let people know what I feel. We certainly can grade. I feel confidently. I feel really strongly about this. But also, I can promise transparency. I can promise honesty. I can promise effort. I can't promise results either. I can't promise outcomes. So let's talk a little bit about, since we got into it a little bit about superficial endometriosis, let's talk about deep endometriosis and kind of the difference between more superficial lesions and deeper lesions.
I have a passion towards deep endometriosis. So one thing that it is really kind of makes me love, have that passion toward the disease is that you probably have less recurrence risk if you do a complete excision, and you probably will have a better resolution of symptoms if you do complete excisions compared to superficial endo. So if you do the more aggressive surgery in deep endometriosis, you're most likely achieving far better outcomes. That's why I kind of think this way about deep endometriosis. Definitely the surgery is very hard. Definitely if you tackle deep endometriosis after hysterectomy, it becomes way harder. Because if people have, sometimes when we do a hysterectomy, sometimes we miss disease, or sometimes we don't dissect enough to find the deep disease, or sometimes we do not do the proper preoperative workup to know that there is deep disease that needs to be addressed during the hysterectomy.
How do you evaluate for deep disease? What's your workup?
So first thing is I listened to your show, and I remember your conversation with Dr. Ted Lee about the value of history taking. I still remember that. And, I cannot emphasize this, this by, very well, that how much you listen to the symptoms and kind of try to think about which symptom can be translated in what anatomical location. Like by listening to the patient, you almost are painting a mental model of the anatomy. What is the location of the disease? And then you can, examination, this is something that we all have been trained during our training about, but utilizing expert imaging, and I cannot emphasize this enough. Ultrasounds are not created equal. MRIs are not created equal. So if you are a GYN surgeon who decides that you're going to treat patients with deep endometriosis, you have to have access to expert imaging. Either you learn how to do ultrasound for endometriosis yourself, or you have a partner or somebody like you can access who knows how to do deep endometriosis ultrasound examinations. And you have also a radiologist who is trained and is interested to kind of develop, MRI experience in deep endometriosis. We have great radiologists, but some of them, they really want to excel in imaging of endometriosis, and some not so much, which is okay. But if you are going to tackle deep disease, you have to have those two team members, an expert sonologist and an expert radiologist.
Do you read your own ultrasounds?
I have a partner who is a GYN sonologist, and she does all my ultrasounds. So
that's great.
I kind of, and she does deep endometriosis ultrasounds. And I ask myself every time, do I really need to get an MRI after her scan?
Oh, wow.
But then we sometimes we still do.
And then you have, assuming a close relationship with your radiologist. And do you have a special pre-procedure setup that you do?
We actually have a multidisciplinary team meeting for pre and post-op patients. So in this meeting, we have, mixed surgeons, we have REI specialists, we have the GYN sonologist, we have the radiologists who are, kind of the team who are interested in endometriosis imaging. We have our colorectal surgeon. So we do this, maybe every other month, and then we go over cases and for surgical planning. And actually we come back and present the cases post-operatively, showing them like the laparoscopy or the robotic images. Actually, everybody learns. We learn together and we get better together.
No, I think that's wonderful. And it's nice that your organization, at least your colleagues are supportive of this, because medicine's a team sport. I've been reading ultrasounds for 12 plus years now. Plus, fellowship and residency on top of that. And I looked at countless MRIs, but having folks who do it and are focused on it and are experts in ways that, I won't ever be, it's really nice to have those people. We're lucky where I am, but when we had Dr. Wendell Van Buren and Dr. Tatney Burden on recently to talk about sort of that relationship and the value in that partnership and using MRI to find those lesions. But I personally use a lot of MRI when I have concerns, primarily if there's like bowel symptoms. I think if it's not bowel related, I feel pretty comfortable. On the bladder, I feel pretty comfortable. The head next to that, certainly I can operate on the bowel, but if you're operating on the bowel and you have colorectal surgeons in your department operating next door, you got to be pretty careful about operating on, in a sense, somebody else's organ, right? Like if you have a complication and you had that expert next door, you have to be asking yourself, why would you not ask for their help? And luckily I've got some pretty, not just talented, but thoughtful and hardworking colorectal surgeons who actually care about endo, which is pretty rare and unique too. So being nice to your friends and your colleagues in the OR, it can end in great patient care. So using MRI, so symptoms, we've gone through this a little bit, but some symptoms that make you think more about deep end infiltrating endometriosis. What are some of the red flags for you in taking history or doing an exam that make you think, man, I probably ought to get an MRI?
So again, listening to the symptoms, and I want to kind of focus about the post-hysterectomy patients, because this is kind of the topic of our discussion today. So patients who had a hysterectomy, and then they come with significant pain. They have cyclic vaginal bleeding after hysterectomy. This is not normal. So this actually raises the flag quite a bit for deep endometriosis of the vaginal cuff. And I've seen quite a bit of this. And you do an exam and there is a nodularity in the cuff. After, like as if there is still a cervix, like you feel that nodularity, very hard nodule at the vaginal cuff, and the patient has total hysterectomy. And you sometimes you're lucky when you do a speculum examination, you show a bluish discoloration of the vaginal cuff. It gives you the clue already. But this is rare. Usually you look at it and you don't see much because it is deeper. In those patients, for example, you do your imaging, you do the ultrasound, the special ultrasound, you do the MRI with dye. I have a certain protocol for MRI. So do a vaginal dye and a rectal dye. And then you start to see those lesions. If the patient, one of the other things is that bladder endometriosis after hysterectomy, patients come and, tells you that before surgery, I never get to have a history of recurrent UTIs. And now I have significant recurrent UTIs for years. And then I have hematuria. This is not normal. So you start to think, okay, maybe there was bladder endo that it was left behind. Actually, the bladder endo, it is so easy because you don't do a lot of homework. They come from the urology. So the patient goes to the urologist, hematuria, either cyclic or non-cyclic. They get a cystoscopy. The urologist gets a biopsy, and the urologist is like, he done the homework for you. So you give it to you on a plate. This is a bladder endo, and you have to manage. Same thing for bowel, like rectal bleeding or severe dyschezia that has a trend or a pattern. This is also not normal. So the patient's symptoms, as we talked, give you the clues.
No, I think those are we talked about it before, but listening to your patients, understanding but also knowing to ask the right questions, right? Bleeding per rectum or bleeding in your urine, like certainly, go see colorectal, go see urologist, but is it cyclic? Is it something that, comes and goes? And those are clues. Certainly if you have your ovaries, it makes it more likely that they would be cyclic, but you can also get deep infiltrating endometriosis that is not in the bladder, in the bowel, that's not transmural. And so how do you what are the signs? What are the clues to finding a deep endometriosis that's not in one of those organ spaces?
So, the most common locations that, we have seen is vaginal cuff, colorectal, bladder, abdominal wall, and then parametrium. Parametrium is less frequent, but still people can have parametrial disease, and this is the hardest one out of all for many reasons. Number one reason is that there is no specific symptom for the parametrial deep endo. Like bladder deep endo, there is a specific symptom, hematuria, cyclic UTIs. For vaginal post-hysterectomy, cyclic vaginal bleeding, specific symptom. Cyclic dyschezia or rectal bleeding, specific symptom for colon and rectal deep endo. But parametrial deep endo, it does not have specific symptoms except of pain. So you have to do more workup, and it is harder. I think it is the hardest place to visualize. Even if you have an expert ultrasonographer, showing the parametria is the hardest. I would say 100% of the time, patients with parametrial disease, they will need an MRI. And again, not everybody can read those MRIs, because think about post-hysterectomy, there's a lot of scar tissue. Actually, in imaging for ultrasound and for MRI, we look for organs that we are familiar, and then we build the image around it. So we start by looking for the uterus, right? The first thing you do when you do a transvaginal ultrasound is that you find your uterus, and then you look around the uterus. Post-hysterectomy, there is no that defining organ that you can start your scan with. So you lose your pivot point that you relate to, and then you start to, to find out other nodularity and other locations. Definitely, parametrial is the hardest. Another easy one that gives, the patient gives you the answer for is abdominal wall mass. They come and they kind of take your hand and put your hand on the nodule and say, this is it.
And you're talking about primarily post-cesarean scar abdominal wall endometriomas?
The vast majority are post C-section, but I have seen patients with abdominal wall endo without C-sections. Again,
really?
This is rare. I've seen it in location that was no incision in the past, but most commonly after like a laparoscopic site. And I believe that usually there is some sort of an endometrioma. If you look at one thing I really want to emphasize, if you are doing a repeat surgery of any sort, you have to get the operative note. You have to read the previous surgery operative note. In any
if you can get it.
If you, yes, you have to read the previous surgery note, because most of the common reasons why people have laparoscopic port site deep endometriotic nodules is a non-contained retrieval of an endometrioma. They do an endometrioma and they just pull it through the skin. And those patients come with implantation that forms a nodule in the port site. But you are 100% right. The majority comes after cesarean section.
Yeah, we see quite a bit of those, and those are fun cases. And again, working with your general surgery colleagues, folks that are good at taking care of hernias in case you have to take a bit of fascia out. But so we've talked about kind of the evaluation, the workup. Surgery is really where I think a lot of us get nervous in going back and operating in someone who's had a hysterectomy. Talk to us about some of the challenges, sort of how you approach a surgery if you find deep infiltrating endometriosis somewhere post-hysterectomy, assuming post-BSO as well, or not, I guess it doesn't really matter either or, but talk to me about how you approach those lesions, whether it's bladder, bowel, or parametrial, kind of, rectovaginal is really where I sort of think of the most in those spaces, post-hysterectomy. But talk to me about your sort of surgical approach. Are you doing mostly straight stick, robotic, combination?
So I was doing a ton of conventional laparoscopy, and then I became more and more robotic prone. So now I am maybe 70% of those cases I'm doing it robotically.
Did you train robot primarily or primarily straight stick?
Primarily straight stick. And I did the transition because I have seen, specifically because I do a lot of cases with multidisciplinary team. So I have the reconstructive urologist who, when he hears that I'm doing conventional laparoscopy case, he becomes like really not happy.
Urologists do not like straight stick laparoscopy at all.
Indeed. Colorectal, we have a big division of colorectal surgery, and they are very competent at both ways, so they don't care as much. But I personally becoming like really seeing the value of robotics in those, specifically in those redo surgeries, because the visualization is so much better. You can see the planes so much better, taking into account that the planes are probably gone. And one other clue is that you kind of have to see who was the surgeon before you. If it was an oncologist, you have to be very, very careful, because you know that all the spaces are opened and you have to kind of be very careful. If it is a mixed surgeon who does a lot of endo, you also have to be careful because they do the same approach.
And so those spaces, the retroperitoneal spaces, have been opened and they are no longer, as one of my GYN oncologists, Diane Emad, used to say, the safe port in the storm. They're no longer those places where you can go and go, now I can see what I want to see, because they've been opened, they've reperitonealized in ways that is going to look very different.
So I 100% agree. And you know what I tell myself in every single case? Do not expect to find the organs in the way you expect to find them. So that ureter that you think is sitting in the ovarian fossa going lateral becomes suddenly so medially pulled into the mesentery of the rectosigmoid colon. How? Because of the previous dissection. Sometimes if people open really lateral spaces, I found cases where the external iliac vessels are pulled medially into the endometrioma. So it really depends on who did the surgery and what spaces have they opened. The more spaces they dissected, the more surprises you will see.
They are the toughest cases, and I think those of us who do it a lot know when we counsel patients about these surgeries, why you don't want to just like go in, we can just go back in a few months. Like, if we're going to do this, let's make sure the surgery is one that provides an outcome, because the second, third, and fourth surgeries, and I'm sure you see that. I see it a lot where I am. I'm usually the third or fourth surgery in line, and you go, "Ugh, man, that would be nice if we were called first," but it can be challenging. But yeah, so when you go into those spaces, oftentimes they have been opened up, they have been altered, and so those are the toughest surgeries, I think, that we, some of the toughest surgeries that we do when you add in that and the endometriosis plus the distorted surgical anatomy. So talk about your process. Is it like the same thing every time? Your ureterolysis, do you start higher up in the pelvis where it's sort of been undisturbed? How are you just doing opening everything up first and then going after the lesion? Or are you focusing on the lesion, leaving other stuff behind? What's your approach? I know everybody's a little different.
So yeah, I start high, I start at the brim, and it is almost the same thing. If there is adnexa still there, the adnexa get dissected and it moves out of the way. If I dissect the ureters in all those cases, because the ureter is probably stuck either to the lesion or to the bowel or to the residual adnexa. So freeing of the ovary and freeing of the ureter, this is kind of the start. And then I have that, and it's a bowel disease, so I free the bowel. So if it's a bladder disease, I free the bladder. And you think about it, I use manipulation in all the organs. What is the meaning of that? So I have a vaginal cuff manipulator. It's a post-hysterectomy case. So you cannot use a uterine manipulator. There is no cervix. You use a vaginal cuff manipulator, specifically made for this. You use a rectal probe. In all cases, you have to use a rectal probe. Most commonly and easily available is to use an incisor as a rectal probe. For the bladder, in all these cases, I backfill the bladder to see the contour of the bladder. Sometimes I use a Foley catheter guide, like a guide inside the Foley catheter metal, a guide, and then I kind of push it so I can see the borders of the bladder. For the ureters, I'm becoming a big fan of ICG. Like now in all repeat endo, retrograde ICG, it takes like 3 minutes and you see the ureters so amazingly. And the beauty about this is that, do we need to do ureterolysis in every single case? Probably not. But if we don't see the ureter, we have to do ureterolysis because it's going to injure it. But if you have ICG and the ureter is very far from the lesion, you don't have to fully strip the ureter and kind of risk its vascularity just because. No, you can actually see the ureter very well, and if you don't need to come close to it, don't come close to it. So think about this. In redo surgery, I technically manipulate all organs of somehow, you know what I mean? Of some sort.
So you're not using stents. ICG for the ureters is enough for you to see what you need to see.
I used to use lighted stents, which is an indwelling, stays in the whole time during the surgery. It is 6 French, so it is kind of thicker. And then everybody gets hematuria, at least for the first day. And then when I started doing way more robotics, I found the idea about the Firefly and the retrograde ICG. So there's no indwelling stent. The ureter just has the ICG, injected inside, and the Pollock catheter.
How do you get the ICG into the ureter? Just through ureteroscopy?
I use a Pollock catheter, cystoscopy, and I put the Pollock inside the ureters for like very brief moment. I inject and I remove it away, and it stays. Sometimes I've done cases that lasted for 8 hours, and still you can see the ICG till the last minute. So, you use a Pollock catheter inside the ureter, but you just push the dye, remove the catheter. The ureter does not become like bulky because of the stent inside. So it's kind of practice changing for me.
Wow. There's so many different things that we can do. I mean, it just shows the value of doing tons of endometriosis surgery. And I've operated a lot in the last 12 years, but there's just always somebody doing more. There's always somebody who's thought of things you haven't thought of. And that's the beauty of it, not just the show, but meetings and keeping in touch with our colleagues who do this, because there's always a way to do it better than we're doing it. You have to be open to the idea that even if you're doing great work, there's always that opportunity to think, oh man, let me think about how I could try something new or better. And not that we all have to change everything all at once, but like every one of us has hard cases. And when you get into a situation where it's challenging, I mean, that idea you had would be really helpful right here. So that's something I haven't done. I've never used retrograde ICG, so that's really interesting. And the idea of using a probe every time, the vaginal manipulator, the vaginal cuff manipulator, and the bladder filling every single time, I mean, really is those extra steps that you think, should I do it? Should I not? But if you're doing it every single time, you get used to it. You recognize those visual cues. It really allows you to be a little bit more certain in those areas where there isn't a lot of certainty if you're not really using something to identify those organs.
Yeah, after hysterectomy, and think about hysterectomy itself induces scar formation. Endometriosis itself is a scar-forming disease. Dissection that was done, especially if they have done a lot of dissection, all these factors makes the surgery way harder. And actually, you are 100% right. This is the value of discussing with your colleagues. So, for example, I'm going to tell you something interesting. For abdominal wall endo, for me, that's kind of a really straightforward case. It's a subcutaneous case. You kind of cut on it, you excise it en bloc. If you cut the fascia, you repair the fascia. If you have a very big fascial defect, you have your hernia friend. He will help you. Done. It's not like a big deal. But actually, I just have seen videos lately of people doing laparoscopic removal of the abdominal wall endometriosis. Actually, we did a course at AAGL, and Dr. Ted Lee was one of my kind of co-faculty, and he was showing that, you always think about the abdominal wall endometriosis as it is a subcutaneous superficial facial lesion. But there is some cases that it is a subperitoneal nodule, like you can get access to it from within easier than from without. So he's showing that, like how he did it laparoscopically and put the mesh laparoscopically. Again, this is the same concept that you mentioned. It is the value of we learn from each other all the time.
Lucky to have such talented and smart friends and who are so generous with their time. And so, so many people have, for our patients have spent time with me, have done these courses like you've done, and like our colleagues have done. And so it is the great circle where you give to someone, they give to someone else. It always comes back around. You mentioned that, hysterectomy and endometriosis and prior surgery, all those things lead to scar tissue. So something I've found to be really challenging is to know, what should we be taking out? Like, what is the lesion? What is normal scarring? I mean, because there's plenty of folks that have scarring that don't have endometriosis. Vaginal cuff is a scar. What do we take out and how far to go? And you see a lot of opinions. Oh, this is fibrotic. It all has to come. Or no, here's just the one nodule here. And, are we really going to go through and take out all the scar tissue that in a few weeks will again be scar tissue? And so how do you know what's what?
Again, you're asking very hard questions, but this is actually what I did for myself. When I excise a lesion, I name it in a way that gives me a clue when I review the pathology. So for example, let's say peritoneal disease. When I'm sure it is endometriosis, I have my OR nurse, they call the lesion peritoneal endometriosis of the specific location that it was. When I'm taking a peritoneal area, which I'm not sure what it is, I don't call it endometriosis. I call it peritoneal biopsy suspected endometriosis. So that when I review my pathology reports and I compare my judgment every single time. How many times I was correct? How many times I was not correct? When I thought this is only scar tissue and actually came back endometriosis, when I called it endo and it was not endo. And by time you revise yourself and you keep learning, when you overcall it, when you undercall it. And then after a while, you because you're revising yourself every single time and you're making yourself to go back and look at the images, and then you kind of get better. For the deep endo, when I first started doing deep endo, I didn't know how it looked. Like, it looked funny. This is like not normal. I didn't know what is this. And then again, same philosophy that everything I excise, you have to name it in a way that makes sense to you to be able to judge if you overcall or you're undercall compared to the pathology, because that the pathology is the gold standard.
It takes a lot of repetition and doing, but also those additional steps you're taking of naming it in a certain way is such an ingenious way. Did you come up with that, or is that something that someone else was doing you thought about? Because to me, that's like, it's such a simple,
it's very
easy
simple
thing to do. But when you're doing all these biopsies in some rendo, like I don't remember like which was which, and going back and taking pictures, by giving yourself that little clue, it's such a brilliant, simple little way to sort of help yourself get better at identifying endometriosis. I love that. I think that'll be the thing that I take away the most from this. Is like, it's a little thing that you do that's like, oh my God, it's like so genius.
No, and it's very simple, as you mentioned. One other thing that I really kind of found very important is that you kind of try to fight your ego. Because if you are the endometriosis person in the department, like everybody would say, oh, I'm going to send it to Mark, he will just do it. But every single one of us will have a case that they should not do. So, for example, it is very hard for me to say, I'm going to stop, or I'm not going to start a dissection where I don't see the end clear. Like, you start when you see the end in your mind. So I had patients where there is lesions invading the internal iliac vein. And I kind of say, I'm going to stop. And this is something that, I don't know, some people have a hard time taking that call.
Well, no, it takes being self-aware. It takes being humble. I got some good advice. I think I told Arnie every time I see him, but on the show too, that, he told me when I was coming to Kentucky, listen, you're the first mixed person down there. Certainly we all get good training and fellowship, but you're a new surgeon. You're not seasoned yet. And so don't be a cowboy, because if you do these things out beyond your scope, people will never send you patients again. And it's not good patient care. And so sort of live with that. Your way of saying it is a little different than mine, but in my mind, I have algorithms for the case, right? So if I see this, then this. If I see this, if there's a question mark here, in any one of these steps, don't go down that path, right? If you don't have an answer for what you're going to do in the situation, don't start, because you can't go backwards in surgery. It's really, I tell patients all the time, when you're talking about hysterectomy or some other, IUD or pills that you can stop, or, hey, I can take your IUD out. I cannot put your uterus back. And so, just thinking about, how you get to these points and decisions for surgery, we're really good at taking stuff out. We're really bad at putting it back. And so being able to have the self-awareness, take a step back, big picture. Okay, what are we actually trying to accomplish here? What's the end goal? And will we still accomplish our goal? And if the goal ultimately is patient safety and good outcomes, we have to weigh all of that. And yes, it does take some humility. It does take some ego. And, you don't want to be scared either, right? You don't want to take patients to OR and just kind of dabble around and then they've got a surgery they didn't need. So knowing your skill level and knowing the kind of surgeries you want to do and committing to it, because I think one of the challenges we have in our profession is folks that operate a little bit. And when you're operating a little bit, just like if you did a little bit of OB, it's not fun when you're dabbling in something and get into really challenging things. And so having that self-awareness, that support structure, knowing what your practice looks like, who your partners are, what your support looks like, and that's different for every practice, but knowing sort of where you fit in the scheme of things, and you are not the center of the universe, right, in that situation. So I think that's a great point, and I think that you have to be very thoughtful about that. But yeah, just understanding what's the goal here, why are we here? That's the biggest question we surgeons can ask ourselves, I think.
But one of the things that I really want to mention, that if you really want to do deep endometriosis surgery, you kind of have to devote a lot of your practice to that. So like, I would say at this point, I kind of maybe 75% of what I do is endometriosis. So you kind of, if you like something and you feel that you are actually have passion, it gives you the time and energy to learn more and get better and spend time and not just do it once in a little bit, you do it all the time.
No, and I think that's true. I think, and our fellowships are pretty variable. Some even have some Urogyn, but some are very fibroid heavy, some are very heavy and deep endo. And, where I trained at the time, there wasn't as much advanced endo. And that's something I had to learn about over the years. And I've had some good partners I've worked with over the years, and I've had to develop that skill set. But fibroids, man, we were all over that. And that's a big part of my practice. Whereas some practices are so big in endometriosis. And sometimes you say, listen, this is a challenging case. And I've certainly referred patients to my colleagues, outside of my institution, because it's not about me, and I think ultimately if patients know that, they'll send the word around that you're a good doc and your practice will be fine. This idea that, you're giving up a hysterectomy, like it's not your uterus, you got to make sure the patients are in the right place. And sometimes it's hard for us to admit. It doesn't happen often. It certainly happens less often the longer you do it. But ultimately, I'm in this for good patient outcomes. There's no pride in any of the work that we do. There's no ego. It is simply just trying to surround yourself by good people, good partners, good teammates, good OR staff. And, do the patients deserve us to be paying attention and doing the right thing? So
the other thing that I would add on to, I agree with everything you said. One thing I would add is that you want to minimize intraoperative surprises. So there is no, I'm going to start, I'm going to look and see what I'm going to do. No. Like if this patient has bowel endometriosis, we're not going to find out in the operating room. No. We're going to find out before. We're going to discuss the management. We're going to talk about risks. We're going to have colorectal surgery available, somebody that and you operated with, and not catch him on a fly while he is flying out of town in 1 hour. No, everything is planned.
I am with you. I do not like going, and sometimes it's hard because that means we have to wait a few more weeks to get to the OR, things like that. But I tell them, look, I've said this 100 times, 1,000 times. Patients understand complications. They understand it. Really don't like surprises. And so, listen, looks like there's really bad endo. We may have to do a resection. You may wake up with an ostomy. Is this what you want to do? This is, based on what we're seeing, feeling, finding. This is a significant risk for you. And, we'll try to do a primary anastomosis, but ultimately this is a possibility. And they wake up with no ostomy and they're thrilled. But if they thought they were going in there for a simple hysterectomy and wake up with something like that, that's incomparable in terms of the impact on the patients. You have to do the extra work. And it can be challenging because patients, understandably, they're in pain, they're suffering. We do not want to delay their care. We do not want to delay their treatment. But you got to be the physician and say, listen, I'm sorry, but I need to make sure we get in there and do it right the first time. And so, I think that's how I practice too. I want to schedule it with the people I know that can do the right job at the time. I've got my surgeons that I want to work with. I have my people that I want to be there. I want their input and their availability. Not, like you said, not like, hey, are you around today? Like, what's going on? Where are you? Can you pop in for a few minutes? No. This is a partnership. We are doing this case together. And it's going to be the best thing for the patient. So I love that. That's a great point. And I appreciate it. So I think we've talked really about, number one, that this is something that we have to consider in all patients, even if they've had a hysterectomy. And we talked about this with Keith Isaacson. Peritoneal endometriosis, probably is not the explanation for dyspareunia or uterine pain, right? There's some adenomyosis. And so hysterectomy can be part of the treatment plan for pain. For peritoneal endometriosis, it's certainly deep disease. Hysterectomy is not the answer. And so getting comfortable in those spaces, especially when they've had a hysterectomy, is really that pre-op workup, that pre-op history, that pre-op evaluation, getting all that imaging. And at the end of the day, sending the patient to somebody who's done this a ton. There aren't a lot of mods out there, but there's enough out there doing great work that we need to understand if our patients are coming in after hysterectomy, known endometriosis, you have to have your flags raised, be aware, and think, man, this could be maybe one of the hardest cases we could see, and make sure that our patients get the best opportunities to get a good outcome. So I appreciate it. It's late for you. You've made time for us. I think this is something that I definitely learned from, and I think our listeners will appreciate it too. So Emad, such a good time. Always a pleasure to see and catch up. And thank you so much for coming on the show.
Mark, thank you so much for having me.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orvajinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.